Good. Hello. Welcome, everyone. Good afternoon, good morning, depending on where you're at. Thank you for joining us today for our Auction Therapy and Critical Care case-based series. Today is session 3, Frequently Asked Questions Roundtable on Auction Therapy and Critical Care. Our lead panelist will be Dr. Papytcho, and with him is Dr. Hope and Dr. Nadaba. Just a couple etiquette and housekeeping things before we get started. Reminder that our programming is based on a foundation of love and respect. So please respond kindly rather than react if you disagree with something. It is everyone's responsibility to keep this webinar a safe space. We will be using the chat function for Q&A. So at the bottom of your screen, you can drop your questions in there. Please send all questions through the chat box and feel free to introduce yourself in the chat box as well. We would love to meet you. Please turn on your video if your bandwidth allows and position your webcam effectively to show your face if you're alone or to capture the whole group if you're with multiple people. If you have any IT issues, please send a message through the chat to Tech Support Echo on there. And this session is being recorded and your attendance is consent to be recorded. So thank you. And please be mindful of infection prevention and control. Try to limit the number of people joining from one gathering place and practice physical distancing. And now we will hand it over to Dr. Papytcho.
Good afternoon, all, and welcome to having challenges with my internet connection, but hopefully this time it's gonna work. And today's session, we'll be talking about frequent asked questions about oxygen therapy in the critical care environment. As we know, we'll start by discussing the basics of oxygen therapy. Why is it important to give oxygen? What are the indications and contraindications? And after we do that, we'll go a bit more further, having more discussion on questions we've been asking ourselves about the utilization and then when to use it and how is it used. So the first question that we start discussing is to know for oxygen. Alana, please, can you go up, or Sarah, if your screen? So thank you. So I was asking which of the following are indications for oxygen therapy? Is it hypoxemia, hypoxia, hypercarbia, the 1 and 2, or last as the statement, none of the above? We have different situations in which patient comes and then they need oxygen to be given to them. But most of the time, it's either hypoxemia, hypoxia, or hypercarbia. And in our previous sessions, we had lengthy discussion about hypoxemia and the hypoxia. And later on today, somehow we're gonna talk a bit more about hypoxemia and the hypoxia. So at this time, I can urge our participants to drop their answer in the chat box as we are discussing the answer. Would you please click? Sarah? Sarah, on the discussion box? Please click on the box. The question.
Is this what you wanted, Dr. Papytcho, or you want a different one?
Yes, this one, thank you. And let's go on page 4. Keep on going.
This figure?
Yes. This one. Thank you. So as you can see on this algorithm, it's talking about patients with suspected hypoxia in whom the initiation of oxygen therapy may be indicated. So somehow it's talking about indication of oxygen therapy. Let me say, the decision to start oxygen therapy is after clinical examination by the physician or the healthcare worker who's taking care of the patient. And patient comes with different conditions. And then after examining them, knowing the background of the patient, now you take decision to know if patient is having an hypercapnic respiratory failure or not. For a patient with a respiratory hypercapnic failure, remember that those patients, their respiratory drive is basically based on the carbon dioxide level. So trying to wash it out might affect their respiratory drive.
Hello, Papytcho, are you still there?
I think we've lost him.
I think so too.
Dr. Nadaba, do you want to pick up? See if we can.
Yeah, maybe. Yes, so thank you very much. So I think as Papytcho was saying, the indications for oxygen therapy initially will be based on the clinical assessment of the healthcare provider or clinician or physician who is attending to the patient. And so we have discussed in our previous sessions how the pulse oximeter, which measures the oxygen saturation, becomes key in aiding decision to administer oxygen. So when you do the oxygen, when you measure the oxygen saturation and you find that it's below normal, normally we consider a normal value to be anything less than 94. Of course, we would define the other criteria in the subsequent discussion. And so you would obviously think about starting to administer oxygen. So hypoxia, hypoxemia, any evidence of those two will require that the patient be given oxygen immediately. So again, be reminded that all these resources, this material, you can access them on our Learning Resource Center for more detailed reading. Thank you. So I think the next session, or the next question rather, talks about any contraindications to oxygen therapy. Are there any complications that are related to oxygen therapy? Yeah, so this particular discussion will be led by Dr. Piri.
Okay, thank you very much, Ndaba, for that introduction. So, as we've said, most of this material is already there on the Learning Resource Center, and Alana is beaming. But in the interest of time, what I'm going to do is summarize so that we all understand the dangers of hyperoxia. So there are absolute contraindications and relative contraindications to oxygen therapy. All of these are tailored in two ways. The first is your absolute contraindications would be patient refusal. But remember that a patient who is hypoxic and undergoing hypoxemia is someone who will have confusion as a presenting sign. So you may need to be very cautious of this because there's a medical legal connotation to it. So patient refusal would be a contraindication, but remember to tailor it. However, in terms of other contraindications, we know that certain conditions, you would not be able to administer your oxygen therapy because of the choice of oxygen delivery device. For instance, in neonates who have defects in their airways, you would not be able, for instance, to give oxygen via nasal cannula. So these are some of the device-specific contraindications. However, looking at the complications of oxygen therapy, as Alana was beaming, we know that oxygen has got certain side effects on the body. So potential side effects of oxygen would be oxygen toxicity, which is termed as hyperoxia. We know that oxygen, when delivered into a patient, would cause changes at a pulmonary level. And also, we know that oxygen therapy produces free radicals. So all of these, free radicals or super radicals, all of these would increase the oxidative stress that a patient is going through. There is also a group of patients who Dr. Papytcho tried to earlier talk about, patients who rely on hypercarbia to maintain their ventilation. So depressing the respiratory center. If you take away this permissive hypercarbia, these are patients who you would abolish the ventilatory drive. So be wary of patients who are in a chronic hypercarbia state, such as patients suffering from chronic obstructive pulmonary diseases. Also note that there's another group of patients, our premature babies, typically before 32 weeks. High levels or high FiO2s of oxygen for a prolonged period of time would lead to prematurity, would lead to retinopathy of prematurity. So be wary in this category of patients. Also note that oxygen therapy leads to absorption atelectasis. This happens in certain conditions where as you administer your oxygen, Nitrogen leaves the body by denitrogenation, and then you have collapse of the alveoli. So every time you administer oxygen, you have to look at the type of device, look at the contraindications related to the device, and then you look at some of the complications of administering oxygen. Thank you.
Thank you so much, Dr. Piri, for that very elaborate and comprehensive list of contraindications. And also, I like the way you've clearly talked about the complications related to prolonged oxygen therapy. So this information is important to know that even as much as we need to give patients oxygen, we also need to realize that there are these complications that may arise as a result of prolonged and high flow use of oxygen therapy. Thank you so much. So we move on to the next question, which is asking us to discuss the difference between hypoxemia and hypoxia. So these two terms sometimes can be very confusing, and it's very easy to think that you can use them interchangeably. So we'll watch a very short video. I don't know if that is possible, Alana. We want to watch it to completion, just to show the participants that they can still go to our Learning Resource Center and actually access this video.
Diagnosing hypoxemia requires providers understand its definition and how to detect hypoxemia using pulse oximetry or arterial blood gas analysis. When we breathe, we pull air into our lungs. Room air contains 21% oxygen. When oxygen enters our lungs, it travels to the alveoli, where it's pulmonary capillaries. Oxygen then either binds to hemoglobin within the red blood cells or diffuses into the plasma. This is called oxygenation. Insufficient oxygenation is called hypoxemia. The rate at which oxygen is delivered to the cells and tissues of the body is known as oxygen delivery. Inadequate delivery of oxygen to the cells, tissues, and organs of the body is known as hypoxia. Every cell in the body requires.
Thank you, Alana. Maybe we can just stop there. Yeah, so as we've heard from the clip, please feel free to log into our resource center and actually get to watch through that short video clip. So basically, when we talk about hypoxemia in simple terms, we are referring to a reduction in the amount or percentage of oxygen in blood. Okay, so hypoxemia refers to a reduction in the percentage on the amount of oxygen in blood, while hypoxia refers to the reduction in the amount of oxygen available at tissue level or cellular level for various metabolic processes. So it's important to understand these two terminologies, as one refers to the reduction in the amount of oxygen in blood, while hypoxia will refer to the amount of oxygen available for metabolism at tissue or cellular level. So when we measure the oxygen saturation through the pulse oximeter, we are detecting the amount of oxygen that is dissolved or that is available in blood. And so there are two ways of measuring or detecting the amount of oxygen in blood. You can use a pulse oximeter, which measures your oxygen saturation. And this is a non-invasive device, which I'm sure most of us have seen it before being used in a clinical setting. So this measures the oxygen saturation in blood. And so we made reference earlier on that for purposes of making reference, so the normal SpO2 or oxygen saturation using a pulse oximeter would be any value above 94%. Then you can also use a different method to measure the amount of oxygen in blood. If you have access to a certain device or machine called an arterial blood gas machine, which will measure the arterial partial pressure of oxygen, which is just equivalent to the amount of oxygen that is dissolved in blood. So those two ways can assist you to know the amount of oxygen in blood. And if you're using the arterial partial pressure of oxygen, anything less than 60 millimeters of mercury would be considered to be hypoxic. So you want all normal values to be above 60 millimeters of mercury when you use the arterial blood gas. So that is just the basic difference between hypoxemia and hypoxia. Thank you so much. Is Papytcho back? Or we carry on?
He should be back in a minute or two, but he's not back yet.
Okay, so we move on to the next section or question rather. So which of the following are not clinical signs or symptoms of hypoxia? So this is a question, which of the following are not clinical signs or symptoms of hypoxia? So we have the first one is tachypnea and dyspnea. We have sternal retractions and accessory muscle use. The third option is loss of taste or smell. And the fourth one is altered mental status or listlessness. So feel free to choose the correct answer there and send as we move on to discuss. Yeah, so I can already see we have some responses there already, and all our participants have chosen loss of taste or smell as being not a clinical sign or symptom of hypoxia, which is true. So all the others, tachypnea and dyspnea, sternal retractions and accessory muscle use, as well as altered mental state and listlessness, these will be your clinical signs or symptoms of hypoxemia. So thank you very much. Dr. Piri, do you have anything to add?
Okay, thank you very much, Dr. Spuka. So looking at this question, one way to think about the clinical signs and symptoms of hypoxia is this way. We are talking about respiration, so we're talking about breathing. So most of the signs, the clinical signs and symptoms of hypoxemia will relate closely to the clinical signs and symptoms of respiratory distress. Later on, at your own time, feel free to click onto the link and all the material and the video will show the signs and symptoms of respiratory distress. So a patient who is failing to breathe, a patient who is hypoxemic, this is a patient who, one, will have difficulties in breathing, so they'll have labored breathing. So your patient will have an increased respiratory rate, that is tachypnea and dyspnea. Your patient will have sternal recessions and will be using accessory muscles to try or to labor to breathe. Your patient, later on, as they go into respiratory failure, they'll have altered mental status or listlessness. So these are, or confusion. So these are some of the signs and symptoms of hypoxemia. Loss of taste or smell is a clinical symptom that we have in a patient with COVID-19 disease. Okay, thank you.
Thank you so much, Dr. Piri, for those additional comments. So we move on to the next discussion point. So the next question is what causes hypoxemia and what causes hypoxia. So what are the causes of hypoxemia and what are the causes of hypoxia? So again, remember that the two terms are different. So I defined hypoxemia earlier on as the percentage of oxygen in arterial blood, while hypoxia as a reduction in the amount of oxygen available at tissue level for metabolism. So with reference to hypoxemia, the causes are classified into 4 major categories. And again, kindly feel free to refer to our Learning Resource Center for a detailed understanding of this. So the first category is a reduction in the amount of oxygen within your alveoli. This can be due to the fact that the patient may be hypoventilating, they are not breathing adequately, or their FiO2, or the percentage of oxygen that they are inhaling, is low in the atmosphere. And this is usually seen in high altitude environments where the percentage of oxygen in atmospheric air is low. So with respect to hyperventilating, a patient who is not breathing adequately, maybe their respiratory rate is lower than normal, we can have various causes of this, which may include drugs that depress your central nervous system, drugs that depress your respiratory system, or diseases that may affect your ability to breathe normally, okay? And then other causes such as nerve injuries like your C-spine, your phrenic nerve injury, etc., etc. Those will reduce the ability, your ability to breathe normally. So this may eventually reduce the amount of oxygen that reaches your blood. The other main category is diffusion. Remember, when this oxygen gets into the alveoli in your lungs, it has to diffuse into circulation. And then the circulation picks up the oxygen in various parts of the body. And so anything that impairs diffusion of oxygen from your alveoli into your circulation will reduce the amount of oxygen in blood, leading to hypoxemia. Examples of conditions that may impair diffusion of oxygen would include things like pneumonias, pulmonary fibrosis, any interstitial lung diseases, pulmonary vasculitis, etc., etc. So any disease conditions that affects your diffusion interface or the ability for oxygen to get into your blood from the alveoli will cause hypoxemia. The third category of the causes would be anything that interferes with oxygen binding to the red blood cells or to your hemoglobin. So your oxygen will diffuse into the circulation, but it will not bind effectively to the hemoglobin. And an example of this is in states of where you have carbon monoxide poisoning, because carbon monoxide will displace the oxygen from your hemoglobin. And so this will reduce the amount of oxygen that will be available, that will be present in your arterial blood. The last category is what we call ventilation and perfusion imbalance or mismatch. Anything that reduces your ventilation or the movement of oxygen into the lungs or into the circulation from the alveoli, or anything that impairs the circulation, which is supposed to carry the oxygen from the lungs, will lead to this ventilation perfusion imbalance. So any disease states such as asthma, interstitial lung diseases, or pulmonary embolism, these will affect your ventilation and perfusion. Other conditions, which we generally refer to as shunts, for example, pneumonias, an example of a shunt, pulmonary edema, and ARDS in the context of COVID. These will also affect your ventilation and perfusion. So all of these will cause hypoxemia. So again, feel free to take a look at these resources again so that you can understand in much more details. So with respect to hypoxia, we defined hypoxia as a reduction in the amount of oxygen at tissue level. Alana, kindly move the slides upwards so that our participants can see the breakdown of the causes of hypoxia. So hypoxia is a reduction in the amount of oxygen available at tissue level. And so you would think that one of the main causes of hypoxia is hypoxemia itself. So you have a reduction in the amount of oxygen in blood, and therefore you have a reduction in the amount of oxygen that's reaching. So all causes of hypoxemia would cause hypoxia. The other cause, other category other than hypoxia is anemia. So anemia is just a reduction in the amount of hemoglobin in blood. So there's a reduction in your oxygen carrying capacity, and therefore there's less oxygen reaching your tissue. The other third category of causes of hypoxia would be ischemic. Anything that reduces tissue perfusion, that reduces blood flow to your tissues, will reduce the amount of oxygen that's being delivered to the tissues. Shock states, heart failure, any arterial occlusion, edema, and things like that. These will reduce the amount of blood flow into the tissues, and therefore a reduction in oxygen. The fourth category is histotoxic. So in cases of cyanide poisoning, these ones will also interfere in the amount of oxygen that's being taken up by the cells for metabolism. So all these four broad categories would cause hypoxia. Again, feel free to log into our Learning Resource Center for a more detailed understanding. Thank you, Alana. Maybe we can move to the next section. Yeah, so moving on, the next.
I think Dr. Papytcho is back with us. So whenever he's
okay. Papytcho, hi. Hi, Papytcho.
Dr. Papytcho, your audio is not working. Are you on mute?
Thank you, Sarah. Yeah, thank you, Dr. Ndaba. Thank you, everyone. Sorry, I have to move away from the area where it's raining heavily. It was affecting my internet connectivity. Hopefully now we'll be able to run together in a smooth way, hopefully. Though the rains are here as well, but a bit more better than the other side.
Okay, so thank you, Papytcho. I think you are discussing the next point. What are the normal ranges of oxygen saturation?
Okay, yeah, thank you. The normal ranges of oxygen saturation, I can pick it up, Dr. Ndaba. Thank you.
Thank you.
The normal ranges of oxygen saturation, actually, they depend on the initial condition of the patient. In normal situation, we agree the normal range to be above 92. Some they will go above 94. So for a patient who's known to be in a chronic obstructive pulmonary disease like COPD, such patients, they will have a low SpO2. They need a CO2, a high CO2 level, a high carbon dioxide level in the blood to drive their respiratory drive. In administering oxygen to such patients, you might end up by washing out the CO2 and affecting the respiratory mechanism. Please, could you click on the box, Sarah? Yeah, and then can scroll down. Yes, somewhere there. Thank you. So as we were talking, the discussion earlier on by Dr. Ndaba is quite clear and elaborated hypoxia and hypoxemia and the level of SpO2, because most of us, we rely on SpO2 than arterial blood gas. If you have a chance to do arterial blood gas, you realize that the accepted level should be a PaO2, a partial pressure of arterial oxygen, to be above 60. When it becomes low, then we'd say the patient is hypoxic. So we want to maintain your patient above 60 millimeter of mercury for PaO2 and a arterial blood saturation of above 90. But using a SpO2, you can consider it to be above 92. Some books talk of 92 and other they go for 94. But most of the book, they go for 94% on SpO2. We also have to remember that when administering oxygen, it should be considered to be like it's a drug. So all administer it when it's really needed. Some other situation, patient can still tolerate a low SpO2 without affecting their lifestyle. But when giving them more oxygen, you might cause more damages to their lungs or to their immune system, which can affect their general condition. We should know that the choice of the lower SpO2 should have some limit, okay? Always be ready in a situation whereby if patient is clinically not improving or clinically deteriorating, don't take long to make decision in start administering oxygen than taking chance in delaying, which can worsen up the condition of the patient. Thank you, Sarah. You can go back to the main screen. So here's a question to know if the goals are the same for a pregnant woman and a COPD patient and shock. As we said earlier on, for a COPD patient, the targets or the acceptable range of oxygen saturation can be lower than the pregnant woman and the patient in shock. Remember, the pregnant woman, there's high metabolism rate. The rate of metabolism is high, so there's high consumption of oxygen. So they might need the oxygen saturation, which is above what the COPD patient will need. And the target should be above 94. As we know, a pregnant woman, we don't look at the woman only, but we also look at the interest of the fetus as well, who's getting oxygenated blood coming from the mother. And the patient in shock, remember already in shock, there's poor organ perfusion, which can also affect oxygenation. As it was said earlier on by Dr. Ndaba, that hypoxia is poor oxygen level in the tissue. So if again there you allow patient to stay longer with oxygen in the tissue, which is below the acceptable level, they will go into an anaerobic metabolism, which will worsen up the condition by deepening the metabolic acidosis, which is not good for the patient. Thank you. We can move to the next. And at this point, there's a video that we're gonna play. It's a video that will summarize about oxygen transportation and utilization by the tissue. We'll play a short time of video, maybe 2 minutes or so, and then after that, Dr. Ndaba can summarize for us the video and encouraging the participants at their own time to go through and watch the video entirely. Thank you, Sarah.
Hello, in this video, we're going to focus on lung physiology, focusing on gases and pH. And we'll also look at the oxygen dissociation curve. So air enters the respiratory system in the upper airways, proceeds to the conducting airways, and then onto the respiratory airway made up of the branches of the bronchi, bronchioles, terminal bronchioles, and finally ends in the alveoli. You can think of the alveolus, which is singular of alveoli, as the building blocks of the lungs, where gas exchange occurs, gas exchange occurring between the lungs and the bloodstream. The gas exchange in this case is between oxygen and carbon dioxide, or CO2. So just recapping, the basic physiology: the heart will pump deoxygenated blood from the right ventricle towards the lungs. Deoxygenated blood means blood containing a higher concentration of CO2 with lower amounts of oxygen. In each alveolus, the carbon dioxide will be dropped off and exhaled out of the body, so removing carbon dioxide from a body. And then oxygen will be inhaled and will then reoxygenate the blood. This newly oxygenated blood, or reoxygenated blood, will then go back to the left side of the heart. The heart will then pump this oxygenated blood around the body to the other organs, such as the brain. The oxygenated blood delivers oxygen to organs, tissues. The organ tissues then uses up this oxygen to help create energy in the form of ATP. Now, as a process of creating this energy, ATP, the organs, the tissues will form a byproduct, which is carbon dioxide. Carbon dioxide is then made and is actually expelled into the bloodstream as exchange, you can say. Now, because carbon dioxide is in the blood.
Do you want to keep going or stop here?
I think that should be enough. Dr. Ndaba can just give us 2 words.
Yeah, I think we can. Yeah, I think we can stop here in the interest of time. And just to mention again that our participants can access all these rich resources by visiting our resource center, so that they can watch these clips over and over again, just to consolidate the information. So the video just summarizes the movement of oxygen from the air into the airways, into the alveoli, where it diffuses into the circulation, and how the oxygenated blood is now pumped to the rest of the tissues, where the oxygen will be delivered and where it's required for metabolism. It's also good for us to understand hypoxemia and hypoxia as well, with reference to how the oxygen is moved and it's delivered into the tissue. So kindly log into our resource centers to access these materials.
Thank you, Dr. Ndaba, for the nice summary. As we are moving on, we move into another chapter on when starting oxygen, when to take the decision of starting oxygen, and the titration of oxygen, when to take it up and down, the use of pulse oximetry, and the duration of oxygen therapy. These are usually challenging situations that we face in our clinical setup. You do know when exactly to start, or sometimes we start oxygen not even when it's not indicated. We just put patient on oxygen, or we delay starting oxygen, which might cause more damage to the patient. Yeah. So the following question is, in which of the following situations should supplemental oxygen therapy be started? So this question will be discussed by Dr. Op Piri.
Thank you very much, Papytcho. So in terms of starting oxygen therapy, the previous section, we learned about the different triggers for different conditions. So in this session, I'll start talking about oxygen therapy in an adult who does not have COPD or who is not pregnant. We've been given different triggers as regards to the oxygen saturation by pulse oximetry, but please bear in mind that the partial pressure of oxygen can change from an ABG, but I'll discuss pulse oximetry. So the decision to start oxygen therapy could be at different triggers. We've heard of 94% in the pregnant population, and then lower triggers for patients with lung disease, chronic lung disease. So patients with hypoxia will present either acutely, or this could be patients who have chronic hypoxia. So assessing the need, you have to look at clinical indicators where pulse oximetry is not present. So bearing in mind arterial saturation or pulse oximetry, you must have an idea. Once you have that idea, you decide which systems, which oxygen delivery system am I going to use. You first of all look at the pulse oximetry value that you have. This will tell you when to start in the oxygen escalation ladder. You also have to consider other factors, such as the patient's comfort, the patient's acceptance of the device. You also have to know what is your target FiO2. What is the fraction of inspired oxygen that you want to deliver to the patient? I'll come back to this when we're discussing patients with COPD. And then you want to know, do I want to control the oxygen, the FiO2 that I'm delivering to the patient or not? You also have to know, do I want to humidify this oxygen that I'm giving or not? Or will I use a nebulizer? You also want to choose a device, an oxygen delivery device that causes minimal resistance to breathing. This is very important if you're dealing with a child or your neonate, because you do not want to increase the work of breathing in this patient. Lastly, if you're in a center where resources are limited, you want to use an oxygen delivery device which is efficient and economic for oxygen. So I'll start by discussing various oxygen delivery devices. Oxygen delivery devices can be classified as either low flow or high flow oxygen delivery devices. And the way you flow in choosing this device, start with the device which is most economical for you, and then you titrate upwards according to the patient's clinical response. So I'll start with, Papytcho, do you want me to get into the devices?
Maybe we'll look at it later on as we are proceeding during the discussion that you do.
Okay, all right. So once a
as
patient—
you talk about non-invasive oxygen therapy in the discussion group.
All right, thank you. So once the patient has been put on oxygen, you have to titrate upwards and downwards. The parameters that you use to make this decision is one, clinical. You have to see, are you getting an improvement in some of the clinical signs and symptoms that the patient had when they presented with hypoxia? You have to use monitoring devices. If you're using a pulse oximeter, are you achieving an improvement in your SpO2 or not? And then when do you decide the duration of oxygen therapy? How soon are you going to move on to another device? When are you going to escalate, or when are you going to de-escalate? You're going to give your device time to work, but with oxygen therapy, the patient's clinical response will give you a very good idea as to whether your device is working or not. So clinical signs such as labored breathing, are you having an improvement with that? Your respiratory rate, the use of accessory muscles, all of these are surrogates that will help you in your treatment, your oxygen therapy. Thanks, Papytcho.
Thank you very much, Dr. Op. Alana, please let's go back to the main screen. In the main section, we still want to discuss Alana, are we there? Sarah, we're used to Alana so much. Today we have to change our mind talking about Sarah.
Is this the page that you wanted?
Please, I would like you to go back to the main screen.
Up at the top.
As we are going back to the main screen, I was saying in this section, we still have a number of topics to discuss. After Dr. Op has taken us through in the situation in which O2 should be started, another question that we do ask ourselves is how often should oxygen saturation be monitored? And how do you titrate oxygen up and down? So, talking about monitoring of oxygen saturation, I would like to remind ourselves that oxygen saturation is a very vital information that we get from a patient who's come in to our emergency room or in our critical area environment with history of dyspnea or hypoxia or anything. You would like as soon as possible or as often as possible to have information for a patient who's on oxygen, how is he faring as he's getting the oxygen therapy. And this should be done as often as you are taking the vital signs. In my view, I think oxygen saturation level should be incorporated as it's being advised by the New Zealand Critical Care Society, that oxygen saturation level should be incorporated among the vital signs. And if you consider it to be also one of the vital signs, you will not miss it when it's being dropped down or when it's escalating up for you to adjust your way of administering your oxygen. And the good things about oxygen saturation is like it's appearing already on a monitor on a screen for a patient who's connected to a pulse oximetry or a cardiac monitor. I know in some other situation, we might not have patient continuously connected to a pulse oximetry or a cardiac monitor because of not having enough for each patient. But every time when you take your vitals, please remember to take also to check the oxygen saturation for you to have an idea on how it's moving. Sarah, please click on the box. And when it comes to titration of oxygen up and down, we still go back to what our previous panelists have spoken about. Depending on the condition that the patient is presenting with, it appears that the choice or the level of saturation is not identical to all patients. There are patients whom you would like to go for very high oxygen saturation, and some, a low level of like 92 is accepted. In this case, I've taken an example of patient with COPD. As it was said earlier on, this patient, they can tolerate a low oxygen saturation, accepting from 88 to somewhere 91, 92. They're already used to such low oxygen saturation that trying to upgrade your oxygen up might affect their general condition. When you check on this same tool, if you go on page 3, you find that it said the oxygen level at which the patient should be given, it's really depending on the patient's condition, as you said. Like in COPD and other conditions, as well as chronic respiratory failure, the preferred method of bronchodilator registration is also associated with the level at which the saturation is. So, like when the SpO2 is less than 88, you titrate to a target SpO2 ranging between 88 and 92. That's for COPD patients. But for patients in shock, you would like to have an oxygen which is above 92, your target being above 95 or 96, so that you are sure that oxygen distribution to different tissue is not affected. Otherwise, it might have great impact on the outcome of the patient that you are dealing with. So in summary, on how often should oxygen saturation be monitored, we would say every time that you do your vital signs, if you don't have a permanent monitor or pulse oximetry attached to your patient, you should be checking oxygen. Or even if it's earlier than checking the vital sign, if your patient condition deteriorates and patient who's on oxygen, it's better to check and know at which level the saturation is. And how to titrate up and down, I would say it again, it depends on the background or the condition at which the patient has come. Remember, patients with COPD, they accept low level of saturation. Pregnant women and patients in shock, please give them a high level of oxygen saturation so that you are not affecting the tissue oxygenation. Thank you, Alana. Oh, thank you, Sarah. Oh, we really have to get used to you, Sarah, being our major host.
No worries.
Then we go to the next question, which will be discussed by Dr. Ndaba. We usually ask ourselves, what are the factors that can interfere with pulse oximetry readings and how to adjust to ensure that accuracy is reached during readings?
Thank you, Papytcho. Thank you so much, Papytcho. I think having established that the measurement of oxygen saturation is key in deciding which patient will require oxygen, it is important that we measure very accurate readings. We make sure that we don't get wrong readings and then either fail to give the patient oxygen or fail to make a decision on how to manage the patient. So we also need to look at some of the factors which will interfere with the accuracy of the pulse oximeter, or some of the things that may interfere with accurate reading on the pulse oximeter. So some of them will include patients who is poorly perfused. For instance, a patient who is in shock states, the BP is very low, they are not perfusing well, their extremities are cold, and so that tends to give you an inaccurate reading. Sometimes you don't even get a reading at all because of that poor perfusion and a poor pulsatile blood on your fingers where you are supposed to put the pulse oximeter probe. So hypotension, patient in shock, you have to be very careful in order to make sure that you get an accurate reading. Things like nail varnish or nail polish, those may also interfere with the accuracy of the pulse oximeter. And so we need to make sure that as we are placing the probe on the patient's fingers, we make sure that they do not have these things that will interfere with the reading, such as the nail polish or varnish. Then a patient who is shaking or who is constantly shivering such that the pulse oximeter probe is unstable on the finger, such a patient, you may not get an accurate pulse oximeter reading. So again, we just need to be wary of this possibility and make sure that we get the correct reading. There are other factors such as ambient light. You need to make sure that when you place the pulse oximeter probe on the finger, you follow the correct orientation and instructions on the probe so that you avoid the external light, the ambient light, to actually interfere with the measurement of that pulsatile nature of blood and the oxygen saturation. The other thing is that you need to make sure that you get the correct size of the pulse oximeter probe, because if you are not using an appropriate size, that may also have a tendency of interfering with the accuracy of the reading. So make sure that you identify the correct size, whether it's pediatric or it's an adult size as well. And then inappropriate placement also. You need to make sure that you orient the probe in such a manner that it fits appropriately on your finger and not the other way around. And normally our probes will have a clear sign or illustration or indication on clear indication or sign on the probe that will help you know which orientation to place your pulse oximeter probe. So ensure that you place it correctly. And then in other conditions such as carbon monoxide poisoning, this may give a falsely high reading of the oxygen saturation. And so you need to be very, very careful as you are interpreting the SpO2 in a patient with suspected carbon monoxide poisoning. So these are some of the things that may interfere with the accuracy of the reading. So it's very, very important for us to get an accurate reading, interpret it correctly, because it makes a difference as to whether the patient, in the management of the patient. Thank you, Papytcho.
Thank you very much, Dr. Ndaba, for that clear discussion. There's also a point that I would like you to take us through. It's like, how long should oxygen be provided to a patient that is hypoxic? Sometimes we put patient on oxygen and then we don't know when to take the decision of stopping the oxygen administration. And it's usually a big challenge for different conditions. Hypoxic patients, like this time talking about COVID, and patients who are on oxygen for different reasons. And
okay, thank you very much, Papytcho. I think the question as to how long the oxygen therapy should be provided to a patient, really, as long as the hypoxemia is present and your initial indications for oxygen therapy are still present, either clinically or using the SpO2 measurement, as long as the initial indication still persists, the patient is still very sick, you will need to continue providing oxygen therapy or supplemental oxygen. That's why we mentioned that monitoring oxygen therapy and response to oxygen therapy using the oxygen saturation or using other clinical signs that we've discussed earlier is very, very important for you to decide whether to continue giving oxygen therapy or to de-escalate or start titrating downwards as you prepare to wean off this patient from oxygen therapy. So for as long as the patient is still hypoxemic, for as long as the patient still has signs and symptoms of oxygen requirement, the patient has to continue receiving oxygen, and we need to monitor the response of this oxygen therapy. And again, remember some of the target SpO2 values that we described earlier with relation to the different conditions, such as the pregnant woman, a patient in shock, a patient with chronic obstructive pulmonary disease. Take note of some of those values that we mentioned. As you administer this oxygen, is the patient responding? And so your decision to stop or to reduce will be based on the clinical condition or clinical response of the patient, as well as your monitoring, your SpO2 measurements. Thank you, Papytcho.
Wonderful discussion, Dr. Ndaba. Thank you. In our lesson plan, it was suggested that at this point we go into a group discussion, breakout. But looking at the number of participants, we may not be able to do that. So I suggest that each one of us, we can still run the discussion as it was assigned for the group one. So Dr. Oak, are we there?
Yes, I'm here, Papytcho.
Thank you. As we are looking at the next section of non-invasive oxygen therapy, humidification, and awake prone position. I know in some other fora you've been, I would say, what's the best way to use here? A master woman in prone, awake prone position discussion and the non-invasive. So maybe this will be a good topic for you to talk about. And later on, added the definition of RDS and some little word about diagnosis. I'm not sure if you can take us through.
Okay, thanks, Papytcho. So you want me to go through proning first?
Depending on what you think that is best, as long as you cover out the point that you should have discussed with your group.
Okay, all right. Thank you, Papytcho, for that. In the interest of time, I think I won't go through the format that Sarah has given us today. I'll just run through so that we all have an idea about awake proning. I think recently, especially with the onset of COVID, we've seen an increase and interest in this simple clinical maneuver. And proning is not a new concept. It's been used in anesthesia. It's been shown to increase ventilation in patients who are undergoing surgery and undergoing anesthesia. So I'll go through some of the advantages, talking about the chest mechanics that happen when a patient is prone and why there's a very cardinal role of proning in oxygen therapy, especially in the COVID era. So proning refers to the clinical procedure of placing the patient with the ventral aspect of the patient downwards. So your patient is chest down and the ventral aspect is facing downward. So what happens in this procedure is that with this position, there's better expansion, especially of the dorsal regions of the lungs, the dorsal caudal regions. And this has been shown to improve oxygenation. It improves the chest wall mechanics. So the prone position has the advantage over the supine position of recruiting and stabilizing the dependent portions of the lung. If you think about it, the lung and ventilation and perfusion, it's like a coil of springs that you hold. When you hold your coil of springs, they naturally collect downwards, as in a spring. So this concept is called the slinky effect in physiology. So with that, you find that in the upright position, most of the lung mass is at the bases. The perfusion is at the base. So you find that the apical regions, the middle regions, these are not well ventilated. But when your patient is prone, you get a more even distribution. So there's recruitment and stabilization of the dependent lung segments. Small studies have been done before, and looking at the pressures, there's one study showed that there was an increase in the partial pressure of oxygen from 47 millimeters of mercury to 53 millimeters of mercury, just by changing the position from supine to prone position. In this position, even the tidal volume distribution in the lung is improved. So there'll be more even distribution of tidal volume, and it reverses the vertical pleural pressure gradient, which is there. And then if you think about it, in the upright position, for instance, you have your left lung expansion being impinged by the abdominal contents and the heart. But once this effect is taken away by the aid of gravity in the prone position, you have freeing of your lung to expand in all regions. So this super added pressure of the abdominal contents and of the heart is taken away. So overall, proning improves your alveolar ventilation and perfusion relationship. So those mismatches which are inherent during respiration, those are sort of minimized. So that's, I think, in brief about pronation. Would you want me to move on to humidification, Papytcho?
Yes, sir. Yeah. So that we
Okay,
keep it running.
Okay.
Thank you.
So in terms of humidification, when you use oxygen delivery devices to supplement your oxygenation, what happens is that most of these oxygen delivery devices, for instance, nasal prongs, nasopharyngeal catheters, they abolish some of those natural mechanisms that the body usually employs when it is participating in respiration. For instance, the upper airways, their job really is to entrain the air and the oxygen, and then they will humidify it, they'll moisten it, and they'll heat up this, this air as it goes to the lower airways. So when you're using oxygen delivery devices, these natural protective mechanisms that the body has are taken away. So going through, I think what Sarah is showing, with oxygen humidification, you just want to use devices that will heat, so that is the temperature aspect. You want to make sure that you want to make sure that this air is heated, it's moistened. So most of the humidifiers that we have, they're classified as passive humidifiers and active humidifiers. But with all of these various types, the goal is, one, to increase the temperature, to increase the surface area. So you're giving more opportunity for evaporation to occur. And then you want to increase the time contact. So this is, you're giving more time and more room for moistening the air, for heating the air. So I won't go into detail, but please rest assured that this resource material is available on our learning resource center. But overall, the goal is that with humidification, you are moistening the air, your secretions in the respiratory tree will become thinned. So without humidifying, you have tenacious, thick secretions, and these may end up blocking your airways. With the use of oxygen delivery devices, you have a dysfunction of the natural mechanism. So your mucociliary escalator system, this is disturbed, and also you can have harm or damage to your epithelia. So it becomes very important to use a humidification device. And these will differ depending on the setting that you're in. You may have nebulizing devices, such as we have with our oxygen flow meters, or you may have an active humidifying device, such as the ones you come across on our Learning Resource Center. I think that is it about humidification, Papytcho.
Thank you, Dr. O, for that good discussion on humidification and proning. Would you want to end up with the non-invasive and RDS?
Okay, so just in brief, I think throughout the whole series, we've talked about oxygen therapy, why we need to supplement, how we monitor. So this goes back to previous lectures. In terms of our non-invasive devices, we have various devices which we've talked about before, but all of these devices, one, for the non-invasive ones, we're talking about devices which do not require mechanical ventilation. If you look at the Learning Resource Center, we have various resources which have been put. So there's the oxygen war chart, which will tabulate the type of devices. So just in a nutshell, when you're talking of an oxygen delivery device, you want to look at 3 aspects. You want to look at how much flows that device can use. So taking the nasal prong as an example, this one can be used in adults, it can be used in pediatrics. The flow rate differs. You can use it from 0.5 all the way up to 4 to 5 liters per minute. How much oxygen it actually administers to the patient, this will be about 28 to 40%. So these are the 3 factors that you'd look at whenever you look at whenever you analyze an oxygen delivery device. So before I go on to talk about the nasopharyngeal catheter, I just want to mention that oxygen delivery devices can be categorized according to the flow rates that you're using to achieve your intended purpose. They could also be classified according to whether the fraction of inspired oxygen that they're giving, is it fixed or is it variable? So the nasal catheter, the nasopharyngeal catheter, these ones are variable performance oxygen delivery devices. Nasopharyngeal infants and children, they'll give dial up flow rates of 0.5 to 2 liters per minute, but they're very effective. They'll give you an FiO2 of 45 to 60%. Our simple face masks can be used in pediatric and adult populations. You have to use higher flow rates, so 6 to 10 liters, and then your FiO2 is about 45 to 60. All of this material, all of these values, you find them on our Learning Resource Center. I'll move on to what I like to call the bigger gun in our oxygen armor. So this is our non-rebreather mask, which has a reservoir bag. So for this one, this is a high flow oxygen delivery device. You can use it in an adult or a child. Flow rates, you'd have to use higher flow rates. So you need a good oxygen source. So 10 liters to 15 liters per minute. And this can achieve fraction of inspired oxygen of up to 100% as long as it is fitted correctly. So there are various other delivery devices. There's the Venturi mask. This one typically used in patients with COPD, but it does have a role in our oxygen escalation ladder. There are various adapters, jet flow adapters, which are attached to it. So it will give a fixed amount of oxygen, a fixed FiO2, depending on which jet adapter you use. Other oxygen delivery devices that we use clinically, just to mention, we have ambubags, we have Walters circuit or C-circuits, which is an ambubag with a flexible bag. We have T-pieces, we use tracheostomy masks, we use anesthesia circuit machines. So there are various ways of administering oxygen. Even on a mechanical ventilator, in a CPAP mode, you can still administer oxygen at a certain level without mechanically, without intubating a patient. So all of those are oxygen. Thanks, Papytcho.
Thank you very much, Dr. Oak, for this last discussion. We'll move into the other section, which should have been discussed by me in Group 2, but I'll take it through in the lab session. Alana, please, can you go up? The next section. Yeah. Yes, there, about the escalation. Thank you. Thank you, Sarah. Thank you, Sarah. Yeah. The next section is to talk about escalation of oxygen therapy and high flow oxygen devices and indication for mechanical ventilation.
It's 17 hours.
Somehow, we realized that some of these questions have already been discussed earlier on by one of the two co-panelists or by myself. But nevertheless, we just come and talk about them, about on how oxygen can be escalated and what decision do you take when escalating oxygen oxygen therapy. When you look at this nice diagram, you found that to take a decision of supplementing oxygen, you give it to a patient who's hypoxic. In fact, by giving that to this patient, it means is in respiratory failure, and you're trying at some point how to release him from either low saturation or improve his way of breathing by reducing the high level of oxygen consumption that is worsening again his condition if the rate of breathing is high. So assuming that the patient is in hypercapnic respiratory failure, and then you have a saturation that is less than 88%. So this patient, you might take the decision to start oxygen. And the device to use for oxygen therapy, we just from discussing them. So you choose a discuss that is appropriate and a flow rate that is also appropriate as you try to check and titrate your SpO2. You keep on monitoring your patient so that you make a decision if you should continue or not. Remember, by monitoring, there's also clinical judgments. There could also be a blood gas analysis, also a SpO2 received from the pulse oximeter. If the patient who's hypercapnic respiratory failure, but having a SpO2 above 88, these patients, they might not be needs for supplementing oxygen, but instead you keep monitoring so that you are able to pick it up when the need of oxygen occurs, assuming that the saturation drops less than 88, then you act as we discussed earlier on. And remember that when doing that, when you do your blood gas, it will give you a result of like pH, which is less than 7.35, and the PCO2, which is elevated more than 45. These are patients that you might need also to consider what type of ventilation will you give. If you think of ventilating them, would it be an NIV, non-invasive, or invasive ventilation? But remember that it's up to you as clinician to make a rapid decision before the condition of the patient deteriorates. If the patient is not in a hypercapnic respiratory failure, it becomes a bit different, and the level at which you start your oxygen therapy differs from the previous one. This one, the saturation level at which you start your oxygen goes a bit down. For a patient who's having a saturation of lower than 85, you would like to start your oxygen and you choose the device that is appropriate and that will make your patient comfortable at a flow rate that will give you an expected result in a short time. But keeping in mind that as you are giving oxygen, oxygen should be considered to be a drug that you prescribe and give for a specific indication with a target of SpO2 ranging within normal or acceptable level, looking also at the patient response during your monitoring. So if the patient who's not in hypoxic respiratory failure is having a SpO2 above 92, it's advised that you keep on monitoring the patient and you look at him. If the saturation drops below 92, you assess and you act accordingly. If the patient needs oxygenation or oxygen supplement, you give them as per requirement that they present, and you use the equipment or devices that is available at your institution. It's also better to insist on the fact that sometimes you might not have all the devices that Dr. Ock mentioned in our institution, but what matters is to know how to use or how to escalate them. What to avoid is to use a device that is low in terms of delivering oxygen. You use it after you've escalated up. So in that case, you are de-escalating or you are titrating again your oxygen level to be low. You might just realize that patient who was already saturating, well, and then the saturation start dropping. All this just because you made the wrong choice in terms of the devices to use. Talking about the other question in this same category is which devices used for high flow therapy. It was discussed earlier on. Dr. Ock briefly mentioned about the devices that used during oxygen therapy. She categorized them among the high flow device and low flow device. So those high flow devices are devices that deliver oxygen which is higher than the inspiratory flow demand of the patient. Remember that an inspiratory flow of the patient of a human being with normal, it's above 20 to 30 liters per minute. So any device that will deliver oxygen above this level is categorized in the group of high flow oxygen delivery device. And a device that will give a flow that is less than 20, that one you categorize this as a low flow delivery devices. Now, the choice of the device matters. Here we talk about the high flow nasal cannula. That's a device that will give you a high flow oxygenation. Now the challenges, maybe I can talk about the challenges that you might face using this device in our setup, is that there's high consumption of oxygen. And remember, already in normal circumstances, oxygen availability is a big challenge in our environment. So taking a decision to use such a device can affect delivery of oxygen to other patients as well who are in need of oxygen. So this decision must be made when you take decision of using a high flow nasal cannula. Just as well, that was just a brief comment about the high flow nasal cannula device. Remember that when using the high flow nasal cannula, there are parameters that you can set. Okay, there you set your FiO2, and when setting your FiO2, your target is to meet adequate oxygenation. Okay, the FiO2 can range from 21 up to 100, and you can also set the flow. And talking about flow, there are different equipment delivering different flow. Some they deliver up to 40 liters per minute. Some they go up to 60, 80 liters per minute. So depending on the device that you are using, you are able to set the flow to meet the demand of your patient. And at the same time, you ease the work of breathing and trying to reduce also the respiratory rate. Some book says that these devices used for oxygen, high flow oxygen delivery, they also offer some PEEP or CPAP, but none has been able to say exactly how much PEEP they offer and at which flow they offer a certain PEEP. And is that PEEP really effective or not? So we are not really sure how much PEEP is being offered, but we believe by the flow that is being delivered is creating some pressure, which is also contributing to play the role of a CPAP or a PEEP. To end the talk about the high flow delivery device, there's also temperature setting on these devices. To set the temperature, it also depends to set the temperature, it also depends on what type of patient you are dealing with. Okay, so the temperature also, we really don't know what is the ideal temperature that you would like to start with. But what is true is that you would not like to give your high flow at a temperature that is lower than the body temperature. Otherwise, you cool down your patient and then you'll be hypothermic. That can also worsen the condition. So the choice of temperature is also depending on the patient's condition and the patient condition, the temperature, that will make your patient a bit more comfortable. Before I end the talk on the oxygen delivery high flow devices, I would like to encourage our participants, if they go on our LRC, they'll find more details and more videos about the devices which are used for delivering oxygen at high flow. I'll move on talking about the indication for mechanical ventilation and how long should it take for SpO2 to be improved. Wow, this is quite tricky. SpO2 improvement depending mostly on the patient condition. Maybe I can allow Sarah to play just 1 minute of this video and then I'll pick it up to talk more about the indication for mechanical intubation.
Before discussing airway management and modes of mechanical ventilation, it is important to review the indications for intubation and mechanical ventilatory support. The indications for intubation and mechanical ventilation can be divided into 4 broad categories: hypoxic respiratory failure, hypercarbic respiratory failure, airway protection, and a non-sustainable work of breathing. Hypoxemia is defined as a partial pressure of arterial oxygen less than 60 millimeters of mercury, or an SpO2 or oxygen saturation less than 94% by pulse oximetry. Although an SpO2 less than 94% defines hypoxemia, oxygen therapies and mechanical ventilation may not be indicated until more severe hypoxemia occurs or respiratory failure becomes evident.
Is that good, Doctor?
Thank you very much, Sarah. We can pick it from there. We can pick it from there and then say, in the both indication of mechanical ventilation, it first starts from the clinician examination and understanding the condition of the patient. After examining your patient, then you can identify in your patient the real signs and symptoms to say this patient, the condition can be improved if I put him on mechanical ventilation, or after the non-invasive or oxygen therapy have failed to improve the condition of patient, and then you want to decide to escalate up the management of hypoxia or hypoxemia of your patient. So as it was said, in this 4 group, 1, hypoxic respiratory failure is one of the great indications of mechanical ventilation. This is why Dr. Ndaba talked about the VQ mismatch, which comes through patients would have been either receiving oxygen but not a perfusion at certain area, affecting oxygen delivery to different level, or oxygen exchange at the lung level. So in this patient, you would like to optimize oxygenation by putting your patient on mechanical ventilation and putting up settings that will allow improvement of oxygenation and ventilation. So patients with severe condition like severe pneumonia, ARDS, or pulmonary embolism, they all fall in this category of hypoxic respiratory failure who might need mechanical ventilation at some point. The other group, it's a group of hypercapnic respiratory failure. Wow. We've already talked enough about patients with hypercapnic condition. In this group, we found patients with COPD, emphysema, hypoventilation, may be due to different reasons, okay? But remember that In this patient, as you are ventilating them, especially the COPD patient, don't wash out all your CO2. As you put up your settings, remember that there's a certain level where a patient must be having some CO2 to stimulate them to initiate their own respiratory effort. Otherwise, you might wash out everything and it will have difficulty in extubating this patient at long term. So remember, when putting up your settings and doing your monitoring, you should have your targets at which you want to reach before to say, let me start weaning, or let me liberate this patient from the ventilation, and let me look at other ways, other means at which I can ventilate the patient or supplement my oxygen. The other category of patient that might require mechanical ventilation is when you want to protect a patient's airway. Patient with poor GCS, with poor general condition, with a dropped mental status, when the Glasgow Coma scale is below 8, you would like this patient to be protected in terms of airway. You would like to have a tube inserted in him so that the airway is protected. Patient who's at risk of aspiration, patient who's at risk of poor oxygenation, you want to improve their general condition, okay? Or patient who's having a low general condition for different other reasons, you also want to have their airway protected. It could be a traumatic patient. It could be a patient who's just clinically sick, deteriorated in the ward, or brought in casualty in a very poor condition. You don't want to waste time by starting phase oxygen therapy. And remember their indication, their condition for you to say, let me put patient on this device to deliver oxygen, like patient who cannot initiate their own breath. Patient who's able to initiate their own breath, it also differ on the choice of way of delivering the oxygen. The last group is patients with non-sustainable way of breathing. So these patients, they will have an increased minutes ventilation, they will have an increased respiratory rate, they'll be using accessory muscles. These are patients that we find usually in the casualty, patients with severe metabolic acidosis, patients in shock, asthmatic patients. Those are patients that immediately when you see them, you want to quickly intubate them or give them a non-invasive mechanic ventilation or invasive based on the choice that you make after your assessment, so that you give better oxygenation. Remember, as we said earlier on, the choice of when to start mechanical ventilation, it's you, the clinician, to make it after your assessment. Now, the question after you've started your ventilation or mechanical ventilation, on how long should it take for SpO2 to improve? As it was said earlier on by one of my colleagues, it depends on the underlying condition and also the settings that you put on the vent. Sometimes patient might take long on the vent. I've known patients ventilated for so long, and patient went to ventilation just after a few days or few hours, condition improved, and then they were put off oxygen, extubated, wean off oxygen, and then they recover properly. So there's not really a timing to say this patient will improve after this timing, after these hours or days. Depends on how patient condition is improving and how it's responding to the treatment that you've given them. Unless if there's anything to add up by my colleagues, I think I'll end up there and encourage our participants, as we say, to go on the website which is free and get access to all this material, and at their own free time, they can read further and understand. And there are also other references that we may not be able to mention here, but it's all available on the Learning Resource Center. As I'm ending my discussion, I would invite Dr. Ndaba to lead us through the last group of questions about oxygen supply, oxygen safety, the rebreathing of carbon dioxide, and reusing of some equipment. Dr. Ndaba, are you still there?
Yes, Papa. Thank you so much, Papytcho, for that very, very comprehensive discussion. And I hope that our participants have been able to benefit from these details. So I'll just quickly run through what would have been our topics of discussion for the breakout sessions. And this includes oxygen supply and safety, as well as aspects of the use of single-use equipment. Yeah, so we cannot conclude our discussion on the administration of oxygen without talking about the sources of oxygen, where this oxygen comes from, and how it's made available in our health institution, health facilities. So I'll quickly run through some of the various sources of oxygen that we have in our different institutions. So, and I think that most of our participants have already seen some of these sources, various sources of oxygen that are available. So we have the simplest source of oxygen, which are the oxygen concentrators. And these are just devices that work with electricity, and so they manufacture oxygen. They are portable, and you can move them between patients or between wards. And so generally, our oxygen concentrators are low flow. They give you a low flow supply of oxygen. So most of them would go up to 5 liters per minute. Yeah, and it's important that we all know about these sources, because they are one of the most available sources that you will find in most healthcare settings. Then the other most available source of oxygen is the cylinder, oxygen cylinders. So oxygen cylinders are also very, very much available in most health facilities as well. And so these come in various sizes. You have the smallest cylinders that we mostly use for transport when we're transporting a patient who requires to be constantly on oxygen between wards or between health facilities. And then we have those big cylinders that we use to in various places, such as ICUs and theaters and our research wards, etc. So the other rare source of oxygen, especially in our settings, is the oxygen plants. So oxygen plants, these manufacture oxygen through complex processes. They manufacture oxygen at a large scale. So oxygen plants will fill in your cylinders. They can also supply through pipeline system. They will supply oxygen into our various wards for use on our patients. And then the last one is also another form of an oxygen plant, which will produce or store oxygen in the form of a liquid oxygen. So this liquid oxygen and the oxygen plant supplies are more or less the same thing. So these are the 4 basic sources of oxygen available in our institution. So then moving on in terms of oxygen safety, I think it is important to quickly realize that oxygen in itself is highly explosive and also flammable. It supports combustion. It easily explodes into flames when it's exposed to heat or is exposed to flames or fire situations, etc., etc. And so it's important that we the storage and other safety issues are addressed in the management of these oxygen sources. So it is important that in terms of storage, these cylinders or whatever sources of oxygen that you have are kept in designated places that are well labeled, and the signage is very, very clear, with certain warning signs placed there to avoid exposing the oxygen sources to flames or fire. So these are very important considerations to make. And so in terms of storage, in terms of movements, there are various ways that facilities have adopted to make sure that oxygen, for example, oxygen cylinders are transported safely. They are kept safely in designated areas to avoid explosions, etc., etc. So oxygen, especially oxygen cylinders, are fitted with proper fitting regulators that should always be tightened to avoid leaks and wasting of oxygen supply. And this is usually done by our colleagues, the biomedical engineers, that will take this into account and making sure that oxygen safety is achieved. Then oxygen supply also comes in, we have two different types of oxygen. There's what they call medical grade oxygen, which we use for our patients, and also the industrial grade oxygen that is used in various manufacturing industries. And so in case of patient consumption, we use what is called the medical grade oxygen, which has less impurities compared to the industrial one. So that's briefly about oxygen safety. And again, we want to encourage our participants to make reference to our resources for a more detailed understanding. Then I'll quickly talk about reusing of some of our medical equipment, more so in our era of COVID. Remember, most of the equipment, especially the consumables, are single-use type of equipment, meaning that you only use it once on a patient and then you dispose it off. But due to a lack of adequate resources, most facilities actually resort to reusing some of the equipment, which is actually meant for single use. And so it's important that we take into consideration the various ways and strategies that we can use to disinfect or to clean or take care of these reusable equipment or equipment if we decide to reuse them. And so there are various ways that can be used to disinfect this reusable equipment. One of them is chemical disinfection, which is the most common form of disinfecting reusable equipment. And here we use chemicals such as the sodium hypochlorite solution that we use, which kills most of the germs and various pathogens. The other method of disinfecting is hot water disinfection. And so whether you use hot water or you use chemical disinfection will really depend on the specific guidelines that come with that particular equipment. So hot water disinfection is just one of the methods that you can use to disinfect equipment. Lastly, some equipment is actually autoclavable, and so we can consider using an autoclave to disinfect some of this equipment that we intend to reuse. And so these are some of the considerations that we need to make as we frequently use things like the breathing circuits, the oxygen delivery devices between patients. And so we need to think about ways of disinfecting these equipments. So I don't know, Papytcho, if you have anything to add to this discussion, or Dr. Piri.
Oh, no, thank you very much. That was very clear. I don't think that there's much to add, just to ask our participants to go through or to encourage them to go through our resources for more information that is there. And thank you very much. We've gone far way beyond the timing. I would like to say thank you to our participants for being there with us, especially to our support team for waking up early in the morning, being with us, and to our friends in India, sacrificing their evening, being there with us. And to you, Dr. Ndaba and Dr. Op, thank you for your time once more. And I hope you'll be there for the next session, which will be next month. So at this point, I would like to end this session by asking Sarah to make the final comment or final announcement. Thank you so much.
Thank you, Dr. Papytcho and our other panelists for that wonderful session. Very informative. So just a reminder to all our participants that everything you saw today, all of the resources, extracurricular things are all on our Learning Resource Center, which we will send you a link to this with our follow-up email. We also have a WhatsApp group. So if you're interested in staying in touch, scan this, join our WhatsApp group, and feel free to ask us any questions you might have. And Alana, you want to go to the next slide? Otherwise, you can email us at echo@assistinternational.org. And just a reminder that our next session is on Thursday, April 15th, and we'll be talking about referring patients to a higher level of care. Thank you all very much. Have a great rest of your day.
Thank you.
Thank you, Sarah. Thank you all.
Bye-bye. Thank you.